Would like to welcome you all to the first annual, or the second day of the first annual Global Health Conference of the Houston Global Health Collaborative. Today we have 180 people registered, so we anticipate more people will be trickling in throughout the day, but we're going to go ahead and get started. We had a great time last night. Dr. Robbins and Lisa Strader from the Triangle Health Collaborative presented, and it was very good, and we all got to mingle and see the wonderful posters, and that was very good. My name is Michael Goodman. I'm one of the founders of the Houston Global Health Collaborative. We started back November 2011, actually, was the first conversation that led to this weekend when we were dreaming about bringing the different institutions together to have a middle space to do collaborative work for research and service and education. So welcome. I would like to introduce those who are on the executive committee who are in the room, and then there'll be some others who you can meet later. This is David Philpott. He's a public health student, MPH. He is in charge of the technology. He's a techno chair. This is Rachel Davis. She is in charge of the program. So if you have any questions about program, she's a great person to turn to. This is Ed Pettit. He is a co-chair of the conference. Cecilia Ethan is in charge of the abstract committee. So again, welcome to you guys. Our keynoters this morning, I met Drs. Kim and Ahmed. I usually call them just Maria and Saeed, so that's more natural for me. But I met them in Malawi in 2009, I think, in July of 2009. My wife and I were there for a month, and there are these two dynamic people who did the bizarre thing of going into the community, leaving the clinic. And most of the other doctors were in the clinics while they were going into the community. And there was this sort of ethos about them that said they wanted to know what was going on in the community, wanted to be responsive to what was going on in the community. And when you meet them, they just have a dynamic personality. And that was the first impression that I had of them, and that's grown ever since. They met when they were doing residency in Columbia, in New York, in pediatrics, and they've been in Malawi for about 5 years, and they have a really tremendous community health worker program there called Tengate, and that means yes we can in local Chichewa. So very excited about you guys being here. Thank you for coming, and let's hear your talk. Thank you.
Sorry, let me just get this queued up. All right. Thanks very much for that introduction. Maria and I are so happy and honored to be here today. To be honest, we were a bit surprised when we received the invitation to give the keynote address. As you all know, there are some true titans, huge names in global health and international medicine here at Texas Medical Center and its allied institutions. Maria and I, we're not in that esteemed group. We're both junior faculty. We completed our residency 6 years ago, and we're still at the relative beginning of our career. So when we got the invitation, I gave Michael a call and said, what do the organizers have in mind? Why us? And he said, well, Saeed, Maria, Mark Klein and Peter Hotez are busy this weekend. He didn't say that. What he did do was tell us a little bit more about this conference and how it's a completely student-initiated, student-organized, student-run conference, which would largely be attended by students. And I think that's really incredible. And before we move on, I'd like to give Michael, Ed, Eric, Sam, David, and all the other organizers a big round of applause for their vision, their perseverance, and their hard work in making this come off. So when we learned that this was a student-led initiative, we knew what we wanted to talk about. What we think this conference represents is a profound desire by you, undergrads, medical students, public health students, nursing students, to have an impact in global health, to make a difference in the lives of those who are suffering and in need. The question for many of us, including Maria and myself, is how do we do that? How do we make a difference? What is the path? So in that vein, sorry. Let me go back. Hello. Anyways, simulcast. So in that vein, over the next 30 minutes, Maria and I are going to veer off from the more traditional science talk and tell you a little bit more about our story. We want to discuss in particular how collaborations have not only supported our work, but enriched our lives. By no means do we have all the answers, but we do have some suggestions, and we hope that by sharing our story, we can give you some practical examples of how you can further your own work and careers and really demonstrate that we can all make a difference. So I'm going to start off with some of our formative experiences. I'll describe the Tingate program and what it's done so far. I'll go to collaborations here at Texas Medical Center, and then hopefully we'll have some time for questions and discussions. So our story starts here. Not exactly, but I will point out the early academic exercises. Let's move forward to undergrad. Are there any undergrads here? Excellent. Awesome. You guys are way ahead of where Maria and I were at your stage. Maria and I, we both majored in history, and we were very interested in social inequality and what could be done to improve that, what could be done for development. And we came to the conclusion that medicine and public health could be vehicles for positive social change. So coming out of undergrad, we had this vague idea about what we wanted to do, but it was really in medical school that we explored this practically. How many medical students are here today? Public health students? Nursing students? Awesome, fantastic. We have a lot of students come to us and say they're having difficulty with finding that meaningful experience, that life-changing experience. And I want to assure you that it's okay. Maria and I, we both did the medical mission trip to Honduras. We did shadowing in Guatemala. And that's a good place to start. Just being on the ground, experiencing what it is like to work abroad has value, but you don't want to stop there. You want to continue to develop. And for Maria and I, it was working on our thesis that was really impactful. I went to South America, to Cali, Colombia, to work on vaccine development for parasitic diseases. Maria did a public health policy internship focused on healthcare in North Korea. And we learned a lot from these experiences. I learned that I was absolutely terrible at bench work. Maria learned that public policy research was probably not where she wanted to go. And we both realized that we wanted to focus more on clinical work. So this leads to our first two suggestions. One is that everybody needs to start somewhere. So grab what opportunities you can when they come and try to make the most of them. The second thing we would suggest is to write a thesis. Now, it's not in the culture of every institution, but writing a thesis really gives you the opportunity to delve in depth into a topic and develop a close relationship with a faculty member, which are both important. So it was during the transition from medical school to residency that Maria and I first met. We were both interviewing at Johns Hopkins, and we had some time in between interviews that we needed to kill. So we said, why don't we go get some coffee? And we sat down for about an hour. And during that hour, we both realized that we had very similar hopes and dreams, but absolutely no idea how we were going to get there. That hour may have been one of the most important in my life. Now, we all need collaborators. You know, I honestly don't think that any of the things we're going to describe would have happened if I hadn't met Maria. Now, I'm not saying that you have to fall in love with your colleagues. They don't have to be your soulmates. You don't have to start a family together. But we all need help and support for our work. And I think that's part of what this conference is about. It's about learning what we're all doing, supporting each other, and developing positive collaborations. That critical collaborator you may need might be here in this room. They might be sitting right next to you. So keep an open mind and keep your eyes peeled. Sorry. Maria and I went on to do residency at Columbia Presbyterian in New York City. Any residents here? No, that's understandable. Residency is a tough time to do, to pursue global health. You have to focus on your clinical duties. Your training takes first priority. But for those of you who are medical students and are going in that direction, you have to remember that residency is training. It's not just a job. And so there's an agreement there. As long as you work hard, the program is there to help you get to where you want to go. And for Maria and I, we really had to insist on that. We didn't have any call-free months, so open time to travel and do global health rotations during our residency. So we had to cover each other, and it was challenging. But I'm glad we did it because it was these experiences during residency that really gave us some direction. In my third year of residency, I went to the Dominican Republic for 3 months to work in a small HIV clinic. HIV care for children was just getting started, and ART was not routinely available. Mothers, often from sugar plantations, working on sugar plantations, would come and drop off their 6 children, and we would take care of them kind of day and night. It was a really powerful experience and kind of combined medicine with nursing and family care. And it had a profound impact on me. There were 2 cases in particular that stood out. On the left was a little boy named Arturo. On the right, another child named Jensen. They were both severely malnourished and very ill. Arturo on the left was a year of age. Jensen on the right was almost 4 months, but they looked like they could have been twins. I took care of them day and night, and Jensen on the right did really well and went home and is still doing well. Arturo on the left, despite our best efforts, died. And this experience really stuck with me, and I was fixated on the time of presentation and convinced that if we had found Arturo earlier, we would have had a different outcome. So that experience really helped me decide what I wanted to work on. Not long after, a few months after this, Maria went to the BPI clinics in Botswana and Lesotho. And whereas I saw a small trickle of patients, she experienced a flood. And she saw the incredible good that could be done with proper resources. During this rotation, we met 2 of our biggest supporters and mentors. On the left, or on the top, Dr. Mark Klein. In this picture over here, on the right is Dr. Peter Kazembe. Dr. Klein is, I think many of you know him, he's the founder of Beef High, and he offered us the opportunity to be part of the inaugural class of the Pediatric AIDS Corps. Dr. Kazembe is one of the first people in Africa to treat children with HIV. He was one of only 2 pediatricians in Malawi, and he's the executive director of the COE in Lilongwe, Malawi. And he's the one who really welcomed us to Malawi and facilitated our work there. None of the things that we have done could have happened without these 2 men. So, third suggestion, find mentors who will support you in your work. It's absolutely critical. So in 2006, Maria and I are here in the middle. We joined the first class of the Pediatric AIDS Corps, and we headed to Malawi. Malawi, it's a small country in East Africa. It has about 14 million people, almost 1 million with HIV. Estimates that there are around 150 to 170,000 children who are infected with HIV, with 30 to 40,000 babies born every year who contract the virus. HIV in children is especially problematic. It's a rapidly progressive disease, which is a bit different than the disease in adults. You have 50% mortality by 2 years of age, 75% by 7, but it's very responsive to treatment, so early diagnosis is critical. This is our Center of Excellence in Malawi. It's one of the nicest facilities I've ever worked in, much nicer than our clinics in New York City, actually. And it opened in November 2006. We knew, however, that despite how nice this facility is, we could not address the needs of the hundreds of thousands of children affected by HIV in Malawi, just in the COE. So pretty much almost immediately, we started a program of education, training, and mentorship at Ministry of Health facilities throughout Malawi. Marie and I took responsibility for 3 especially high burden sites that had a combined catchment area of around 500,000 people. We did a basic education kind of here on the right of all the clinical care providers there for a week. And then we would go back regularly, once a week, twice a month, and see patients side by side with the clinical care providers. It was a pretty intense intervention. This effort really did help improve clinical care. The clinicians felt more comfortable with taking care of kids. They saw that kids could get better. And we made a lot of saves. Kids that we were quite sure would not do well, would die, improved and returned to health. And that was encouraging. But there were still some big problems. Kids would come late. They were very sick when they arrived. They had poor adherence. There were a lot of defaulters, and we had no system in place to bring them back into care. But most concerning was that kids in general were not coming in. And what this graph shows is that whereas enrollment was steadily rising at our Center of Excellence, at these satellite clinics, it was static. And so we knew that for every child that was coming in and being started on care and treatment, there were 50 to 100 who were out in the community dying undiagnosed. So what was happening? For us, this was really our aha moment. The light bulb went off, and we thought, here is somewhere where we can have an impact. We wanted to see how we could improve identification and enrollment into care of infants and children infected with HIV. That's the first problem we wanted to tackle. At the time, there was a lot of literature coming out from Partners in Health and other organizations about the positive impact that community health workers might have on HIV and TB care. Community health workers, they're a large potential workforce. Human capacity in Malawi is one of its most important but underutilized resources. There's about 85% unemployment in Malawi. Average yearly income is somewhere around $200. So you could start a program using community health workers and pay them a very good living wage for around $50 a month. So who are our community health workers? We had some people in mind that we had gotten to know and wanted to use. And this is one of our first community health workers. His name's Godfrey Piri. He graduated high school and was studying graphic design but was unemployed. He had a few family members who were HIV infected, and he would bring them into the clinic. He was such a dedicated caregiver that we offered him a job at first as a translator. After a few months of working with us, he could pretty much do the medical interview without us. He would just tell us the answers. And if we had any issues with patients, follow-up, defaulters, he would often offer to help. We knew that if we gave him the opportunity, Godfrey could be a leader in his community and could really make a difference. So it was with people like Godfrey in mind that we made a small application for a small grant from the Clinton Foundation. Our first group of community health workers named the program together Tingate, which roughly means together we can do it, or yes we can in the local Chichewa language. Godfrey actually drew our logo here. And we got started. This was our first class of community health workers in 2008. We gave them about a 1-month training in pediatric HIV, home health care, and HIV counseling and testing. They taught us about their communities, beliefs, concerns, and together we strategized about the best way to do education, the best sites to do teaching, who the important community gatekeepers were, and how to do HIV testing in communities. We started off with community sensitization with the gatekeepers, the chiefs, traditional authorities. We met them in their homes and in their communities, and we invited them to the COE to come in for training. At this first training, they remarked this was the first time, they're often consulted for projects, but this was the first time someone came in and taught them something and actually got them involved in the project rather than just seeking their rubber stamp. We did huge community mass sensitizations. We had thousands and thousands of people attending. This is one of our program directors, or started off as an outreach coordinator, program director now, Kanwani Kanjelo. Another huge mass sensitization. Our community health workers do daily health talks at the health centers. Patients come in the morning, they queue up, and it's an ideal time to try and deliver healthcare messages. At the time, our program was one of the first to do community-based HIV testing. People at the time had thought that it was too much of a no-no. There was too much stigma, there was too much concern. But we received the go-ahead to give it a try, and it's been very successful. People often feel more comfortable within their home. They're not worried about other people seeing what the results are. There's less crowding and it's a better venue for doing true counseling. Our community health workers travel through the community on bikes, relatively unmarked so they can move pretty anonymously, and they're able to reach quite far distances to support their clients. Our community health workers don't just do testing. When they identify someone who's infected, they don't just give a referral. They actually follow them into care, and once they're in care, they visit regularly to make sure their patients are doing well, that there are no problems. They try and serve as advocates for their patients throughout the process. You know, these activities really worked. Here you can see the start of our program, and we experienced an explosion in enrollment. We went from 3 patients per month before the program to roughly 30 patients per month, a 10-fold increase. Our overall enrollment at our 3 initial pilot sites went from 50 to 2,500, a 50-fold increase. We added additional sites, so our overall enrollment exceeded 4,500 patients. These are all patients that would have likely gotten sick and died if they had not been identified and brought into care. We received a lot of positive attention in the press in Malawi about what we were doing, and requests to expand our services further. So this is kind of where we got started. We had some initial success, which we were happy about. And I'll turn it over to my beautiful and brilliant wife to tell you about where we took it from here.